Albert Einstein quoted that intellectual growth should commence at birth and cease only at death. With that quote, I am Jessie Priyanka, the host for this wonderful evening of Scientific Feast, focused on new approaches and methods in fertility management. Respected doctors, a warm welcome to each one of you present here on behalf of Baby Scince IVF Clinics. It's a privilege to talk about our organization, what we believe, and what we practice. Baby Scince IVF Clinics was established in 2020 in Bangalore, intending to provide affordable, world-class fertility services across the country. We aim to become the largest fertility care provider in the world with latest technological innovations and state-of-the-art infrastructure. We are committed to create a holistic fertility care ecosystem for solving all infertility-related issues with technological innovations and clinical excellence. We strongly support clinical research and development for the benefit of our patients. We endeavor to create unique fertility programs that can make significant contributions to ART. Our strong pillars, our most experienced and expert clinical team, all latest infrastructure and techniques, transparency and ethical practice with compassion and empathy. Our aim is to open 36 IVF centers in a span of 3 years across each corner of India so that IVF treatment will be easily accessible and affordable to subfertile couples. Moving on to introduce our first speaker for today, Dr. C.S. Manjunath. He is the Medical Director and Senior Fertility Consultant at Baby Scince IVF Clinics. Sir has completed his MBBS and MS with first position in 2006 in OBGY. He also has fellowship in gynec endoscopy. He has more than 15 years of experience as consultant, laparoscopy, and fertility specialist. He is the chairperson of Karnataka chapter of ISAR 2021 to 2023. He is also executive committee member of Bangalore Society of Obstetrics and Gynecology and a member of many societies like ISHRE, American Society for Reproductive Medicine, IAGE, and FOGSI. He is also a fellowship trainer in Baby Scince IVF Clinics. He has trained more than 140 gynecologists in laparoscopy and infertility. He has conducted many free infertility and laparoscopy workshops across India, Nigeria, Ethiopia, and Bangladesh. He has many publications to his credit and has contributed many chapters in infertility and gynec laparoscopy books. Sir, over to you.
One of you, and thanks for coming on weekdays, traveling. I know the Bangalore traffic is, and my warm welcome again. So I will be talking few things about the recent ART laws, and which I think we all need to know as it has become a law. It's no more a bill. Till 2021 December, it was a bill. After 2021 December, it has become a law. So this law is very much required. Actually, we were all eagerly waiting for these laws and regulation to come. Actually, we should regulate ourselves to serve this particular field in a better way. So, but this law has come with lot of ambiguities. So there are still many more rules and regulation are yet to come, which will be favoring for both consultants and the infertility populations. The disclaimer, this is not the final statement or legal opinions. For detailed information, please go through the Government Gazette and legal opinions. Points discussed here may or may not change. Myself will not be responsible for any legal confusions. We are not antagonizing any government acts or rules. These are the two, there is a two-part to the law. One is ART Regulation Act 2021 and the Surrogacy Regulation Act 2021. Each are separately dealt. How is it regulated? By a National Assisted Reproductive Technology and Surrogate Board. It's a national central board. Under that, each state is going to form a state board. And at the central level, there will be a NARI registration, that is National Assisted Reproductive Technology and Surrogacy Board Registry, where we need to, that's called as National Registry, where we need to send each and every document. Suppose even if you are doing an IUI in your clinic, that has to be registered, and you have to send those details every month. How you send the PCPNDT Form F signature with full documents. So each month you will be sending those documents to the respective state board or to that national registry. Registration process for clinics involves so many things. Please go through that. There are applications, specified applications, everything. That again, the certificate has to be displayed. How you display the PCPNDT form, it has to be displayed in a prominent place in your clinic. And the fee, there is a fee prescribed for level 1, level 2 and the ART bank. And every 5 years you are going to renew that. One thing, even in IUI cycle, that is level 1 clinic, you should form a grievance cells. If any patients has some kind of problem or a complaint, they should approach that grievance cell. And the grievance cell should include the psychological counselor and the reproductive practitioner inside that unit. The reproductive, any ART procedure can be done in a woman between 21 to 55 years and man between 21 to 55 years. So again, this may change, may not change the upper limit of the age. We are still waiting for that. One thing you need to notice here is if suppose a 19-year-old girl comes for you for any ovulation induction, please try and avoid till 21 years. Obviously, that's sometimes in case of if the tubal block at 19, 20 years comes, we should ask them, unfortunately, ask them to wait till 21 years. Basic data to be submitted, the enrollment of the commissioning couple, what are the data you're going to send, the complete details of the couple with Aadhaar card, even including the gamete donors, procedure being done, outcome of the procedure, that whether that pregnancy happened, any abortions, live birth, any complications, all those things has to be sent to the national registries. Clinical procedure related, few things I will just highlight. There are plenty of things. We are not supposed to transfer not more than 3 embryos. No mixing of gametes in one treatment cycle. Suppose if the husband has very low count, if you want to do splitting of the 5, suppose the lady produces 10 eggs, and if earlier we used to do 5 eggs with the husband's sperm, 5 eggs with the donor's sperm, we used to keep it separately but transfer in a different cycle, but we are not supposed to do that splitting anymore. And the splitting of donor egg is again totally banned. Only 1:1 donor. So that becomes financial burden for couples again. Age of the gamete donors, everything is clearly mentioned in the things. I'm just going to skip this. Please go through this thing. Only again, donor has to be selected or taken from the registered ART bank. One big thing, again, when you are taking the donor thing is, please ask for identity, especially the Aadhaar card. And one, I would rather say bad or this thing is, we need to extract only 7 eggs from the donor. We don't know how to do that. So what if they produce more eggs, what to do that? Because it's not in our control. But one advice is, stimulate mildly. Don't stimulate heavily so that we'll not get into the legal issues. Again, sperm donation, the age, screening, all those things are specified. The surrogacy law, this has made very strict because the punishment they have prescribed is 10 years imprisonment and a huge amount of fine. So we need to be very careful when we are doing a surrogate. Again, commercial surrogate, traditional surrogacy is totally banned. Only altruistic gestational surrogacy is allowed. What is altruistic surrogacy is the surrogate mother should come freely without expecting any monetary benefit. We don't know how we are going to do that. But one loophole they have kept is you can provide surrogate with a kindness. Means for traveling expenses, for diet expenses, for her other expenses we can show and do the things. Intending couple, they have defined clearly everything. Only thing is the surrogate mother the couple has to, not the surrogate mother, the intending couple has to get a certificate of eligibility and essentiality issued by a specified authority like district medical board and a state ART and surrogate board. After the birth of the baby, the intended couple has to go to the magistrate court and get the birth certificate. When it means birth certificate will be issued only if we have magistrate court permission. So all those things has to be, unfortunately, we need to deal with all those things. Again, they are specified clearly, the surrogate mother, everything. Can surrogate withdraw her consent? Again, this is any time surrogate can withdraw her consent. So today, if suppose there is an embryo transfer for a surrogate mother, today just before embryo transfer, she can withdraw. No, I don't want to become surrogate. So that kind of freedom has been given to surrogate mother. But once the transfer is done, then that's silent, the law is silent on that, whether she can terminate. Suppose if they are running pregnancy around 12 weeks, she can terminate or not, that is silent on that aspects. Again, they have clearly specified clinics, IUI clinics, IVF clinics, ART banks, what are the requirements, including equipments, persons involved, everything. For a ART level 1, where you are doing IUI, it's a 50,000 registration fees. These are the minimum requirement like gynecologist, equipment, documents, grievance cells, prepare sample. Earlier used to do, like in your clinic, you used to get the sample prepared from the lab and you can do the IUI in your clinic. So that cannot be done anymore. So you have to do only in a registered ART clinic. So if you want to do IUI, the preparation has to happen in your clinic, and again the IUI procedure has to happen in the clinic. You cannot transfer the sample from one place to other. Again, there are specified requirements for the level 2 clinics, that is IVF clinics, how the gynecologist, what are those criteria, andrologist, counselors, embryologists. They are given a big eligibility to be called as a senior embryologist. Consent forms, they have given various consent forms. So the laws are really not, I am not here to scare you, but we need to follow the structured way. I agree there are so many confusions in law. Maybe in future, in few months, all those confusion will be clarified. With this, I just wanted to go for the next topic. Okay. The immune modulation for fertility management. I don't want to bore you with basic things or anything. I just wanted to highlight that the immunology part of the fertility is coming up with a great advancement. I think the future, we need to go into the depth of immunology part of the infertility management. Among the various process in entire human being, the most fascinating process is the implantation of the embryo. I still remember my guru, Dr. Nirmala Madam, used to counsel the patients why some patients used to call the implantation failure when they come with a failure, why it has not happened. She used to tell the implantation process is the one which is very difficult to understand because more than 20,000 chemicals are involved in that. It's really, really that much complicated things. Yes, agreed, if everything happens in 85% of the couples, it just happens naturally. But in another 15% of the couples which things doesn't happen, then we need to go into the depth of implantations. So pregnancy is a semi-allograft, means to say the 50% of the antigens or the 50% of the proteins which comes from the other partner, which is easily accepted in most of the people. So why this happens, how beautifully it happens, it's really fascinating. You all know that 60% of the pregnancies are unnoticed. It doesn't come into the clinical picture at all. Only the 40% of the pregnancies will come to the clinical pictures. Like in that again 10% miscarriages and 30% live birth. So this sometimes the endometrium senses that. So that particular embryo is a defective that should not be allowed to get implanted. So that's in that way the endometrium acts as a sensor or a checkpoint and doesn't allow the majority of the embryos which are defective to get implanted. Sometimes if these checkpoints or sensory mechanism is disturbed, then it will allow even the bad embryos to get implanted. So that's how a subsection of the repeated pregnancy loss, RPL, would say that they doesn't have any problem, only the hyperfertility. The endometrium is highly receptive for the defective embryos also. So that is one category of RPL, hyperfertility. We would say that the hyperfertility RPL. So let us go briefly to the pathophysiology of implantation, how the immunology part is involved. So immunological or immunological defect in repeated implantation failure or repeated pregnancy losses is mainly diagnosed by excluding all other known factors like defective embryo, genetic abnormality, all those things are ruled out, then the immunological cause is diagnosed. Some of the modalities to investigate like APLA, lymphocyte cross-matching, NK cell, so many interleukins are all, even though it's not standardized, we are started using that, hoping that some kind of immunomodulation, if you do, it may benefit the patient. In this implantation, mainly 3 kinds of immune cells will be involved. The first one is the NK cell, the second one is the monocytes, then the B cell, that is T cell regulatory cells. So beautiful harmony between this and the interplay between these 3 cells will determine the implantation process. So normally what happens in a normal pregnancies, you know there is 2 kinds of immunity, cell-mediated and the antibody-mediated immunity. The interplay between these 3 cells will push more towards Th2 helper cell, which is an antibody-mediated immunity, and suppresses the cell-mediated immunity. So this is what's supposed to happen in a normal implantation and normal invasion of the trophoblast. But in case of failed invasion and abnormal invasion, what happens? The cell-mediated immunity will take over, that is Th1 helpers are tilted, the balance is tilted towards that, and the antibody-mediated immunity is reduced. Why the antibody-mediated immunity is very much required means, as I was telling you, the pregnancy is an allograft. Means the antigen is 50% of the antigen comes from the different human being, means different person. So that this antibody mediated will go and mask those antigens, the paternal antigens, so that this cell mediated immunity is not against those particular antigens. So what all the things these cells will do is It will improve the invasiveness, angiogenesis, decreases cytotoxicity, and makes that as immune tolerance, and it also helps in fetal growth. Even in chronic endometritis, apart from other disturbances and other uterine contractility disturbances, it also hampers the immunity of the immune condition of the endometrium. The master or the brain behind the entire implantation process is this natural killer cells. It's normally, not in pregnancy, normally it acts as the lethal weapon against any foreign antibody or antigen which comes into the system. But in pregnancy, it beautifully converts itself into a friendly cell and allows the extravillous trophoblast to invade and multiply. In case of abnormal pregnancies or recurrent pregnancy losses or recurrent implantation failure, it will act against the extravillous trophoblast and it will not allow that to invade or proliferate properly. It also modulates the vascular systems. One beautiful thing how this interplay between the NK cell and external villus trophoblast is, you all know that embryo growth initially requires low oxygen tension. It won't grow if you have high oxygen tensions. So it beautifully modulates in such a way that these EVT cells will go and plug the vessels, and it will not allow much blood supply to be in contact with the embryo, so that embryo will grow in a low oxygen tensions. Once it crosses around 9-10 weeks, the plugs open, then it will have a more oxygen tension. Tension for which is necessary after that around 8-9 weeks of pregnancies. So NK cell, earlier we thought that it's acts against the pregnancy or against the implantation. It's actually converts from a foe to a friend in reproduction. Not only during the implantation process, which it will act as the pro-inflammatory things, during the second term also, it will act as an anti-inflammatory, which is very much required for the fetal growth and angiogenesis, everything. And during the later part of the third trimester also, it acts as a pro-inflammatory, which helps in parturition. The NK cell defective is not only implicated in RPL and recurrent implantation failure, it also implicated in preeclampsia and endometriosis. One thing about microchimerism is the presence of small number of the cells in a human being which are genetically different. So which typically happens during pregnancy. The fetal cells will go into the systemic circulation of the lady and sits in various places, mainly in the liver and the brain. So this microchimerism, on one side it's good, I will tell you in which condition it's a good, but sometimes it can be a bad. Why? Because the microchimerism, basically it happens like first baby is a male, and the male cells will go and sit in the body of the woman, and subsequently those cells are transferred to the second sibling if the second sibling is a girl baby. That particular girl baby will carry those the male cells or male antigens from the brother. Plus, when she conceives, if the male baby is, if she has a first baby as a male boy, means boy baby, she will again acquire the cells from those boy. So put together that mixture, sometimes it can create a reaction, and subsequently she will have abortions, typically a secondary RPL. It means we can see that a lady who has more brothers and a lady who has a first son boy, sometimes if she has repeated secondary pregnancy losses, we need to think maybe the microchimerism is one which is responsible for. Typically, this patient will have first boy baby. After that, every pregnancy will get lost. And these particular ladies are also prone for SLE and other autoimmune diseases. Danish study, they are really doing a good study on this, where they are clearly shown that first male boy baby is responsible for the secondary RPL. Good thing about this microchimerism is something called as pregnancy brain. More the male baby a lady will have, more the male antigen and male cells, the DNA will go and sit in the brain, which will act against the development of Alzheimer's disease. Maybe nature has, maybe knows that boys will not take care of the mother and she is spared against Alzheimer's disease. So the next thing all need to study is the HLA sharing. More the HLA compatibility, which happens typically if they have married close relatives, inbred populations. So body senses that that particular antigen is also similar kind of antigen to my body, and it won't respond in a, especially this antibody mediated response won't happen properly. That's called an hyporesponsive. So automatically when the antibody mediated things will not happen, the cell mediated antibody will go and attack those embryos. That's how more abortions will happen if they share more HLA antigens between the mother, means woman and the man. If they share more HLA antigens, repeated abortion, again this is the cause. So these are the few things which we need to know in the pathophysiology and the immunology part of the things. So what are the interventions we can carry? What are those evidence based behind this? Let us see. The foremost thing what we many of us will do is the NK cell testing. Again, there are so many controversies surrounding it should be done or whether it's implicated or not. Few studies have shown that ideally, if you think it should be done, the endometrial tissue NK cell has to be analyzed. But the problem with the endometrial tissue is, one, it is not standardized. When we are taking the endometrial tissue, the bleeding from the mother will also complicate. That blood, which is also mixed, will not give you proper the methods to standardize the uterine NK cells. So many of the studies are done on the peripheral blood NK cells. What the ESHRE guidelines say on NK cell is, there is insufficient evidence to recommend the routine NK cell testing. Again, there is no proper treatment based on the NK cell activity. Again, the APLA antibodies we all tend to do, especially on the RPLs, not indicated for RIF cases. Strongly recommends to do this APLA thing. Again, anti-TPO antibody, which is kind of taken as a marker for, along with the anti-nuclear antibody for autoimmune diseases. But whether 75% of the pregnancies are the ladies will be euthyroid, even though if they are antibody positive. So whether such patients has to be treated or not, again, it's a big controversial. The recent T4 life trial clearly shows that even if they're antibody positive and a euthyroid, there is no need to treat them. Again, big controversy on anti-nuclear antibodies. But it clearly says that there is a high incidence of anti-nuclear antibody positive in cases of RPL and to some extent in RIF. But whether that has to be routinely recommended, based on that, whether need to treat, again, a big question. Anti-nuclear antibody testing could be considered for explanatory purpose only. And again, the treatment-wise, silent on the recommendation is silent. The ESHRE recommendation for RIF still in the stage of formation and drafting. What it clearly considering is only the right now recommended is reassessment of the lifestyle factors like weight reduction, stopping of the smokings and other drug abuse, those kind of lifestyle modification, and the reassessment of the endometrial thickness. Can be done is vitamin D, karyotyping, 3D and ultra hysteroscopy, the chronic endometritis screening, assessment of thyroid functions and mid-luteal progesterone levels. Other things are not recommended like microbiome profiling, ERA, peripheral NK cells, uterine NK cells, HLA compatibility, other things are not, even including the sperm DNA fragmentation test. So based on this, what are the immunotherapies we can, even though there is no clear recommendation, some RCTs are showing there is significant improvement when you use some kind of immunomodulation. Some RCTs are not showing. Maybe we need more bigger RCTs, but or I would tell you that maybe we need to identify a subpopulation of RIF or RPL pregnancy which will benefit from this kind of immunomodulation. We cannot apply blindly for everybody as a blanket therapy and say this is not working, this is working, this is not working. So one such protocol is Bondi protocol, where it's a commonest thing we use is steroid and a low molecular weight heparin, which is typically called as Bondi protocol, mainly promoted by Australian groups. They clearly shows that the live birth pregnancies are improved when they use this kind of protocol. The endometrial scratch, which came 8-9 years in a big way, we all started scratching, but ultimately the RCTs are showing that there is a low quality evidence of doing this endometrial scratching, even for repeated implantation failures, leave alone the single failures. The intrauterine HCG, many studies are showing recently there is some kind of significant difference it's making. What the Cochrane says is there is moderate quality of evidences for a day 3, that is cleavage stage embryo, not for a blastocyst transfer. Intrauterine PRP, again becoming popular from last 3-4 years. Many studies are showing that it's significantly favoring the pregnancies. GCSF use either subcutaneous or intrauterine, again it's showing there are so many studies which showing that there is significant. Few are showing it's not significant. Again, we need to wait for a bigger RCTs and guidelines. Atosiban not typically modulates the immune system, but it will reduce the contractility. Significantly improves CPR and live birth, and many studies have clearly showed that it will improve that. Maybe it's a most promising among many interventions. This particular peripheral blood mononuclear cells, which is easy to do if you have a centrifuge, a refrigerated centrifuge, not in a regular centrifuge, maybe taking around 3 to 5 ml of peripheral blood, separating the mononuclear cells and culturing those mononuclear cells with either HCG or a CRH, and then transferring those cells into the endometrial cavity has some kind of benefits. Again, it requires big RCTs. You can see these are all the studies based on the PBMC, the peripheral blood mononuclear cells. Again, majority of the studies are showing that it significantly favors the RIF. So with all these kind of interventions, what I particularly think that we need to select a subclass of RIF or an RPL and direct these immunomodulation treatment particularly to this kind of subclass of RIF instead of practicing a blanket therapy. So for that we need to have some kind of how to categorize these things, how to categorize. In RIF, if you see that some people will have over immune response, some people will have under response. So how to identify that? This is again a promising thing. I think nobody is doing as of now in India. Maybe in future this is the things where we can give a endometrial sample and they do the immune profiling and they will be able to tell you in this particular woman there is overactive immune response, underactive immune response, or a mixed kind of immune response. So it's this particular study which took that few interleukins, CD5 markers. Based on that, they categorized a normal, overactive, and a low active endometrium. So typically the percentage wise, if you see that majority are overactive profile, but significantly the endometrium can be underactive, low activation profile can also be done. Why this particularly things becomes important is for the low activation of immune in endometrium, we can do a scratching, we can do some kind of other modalities, and so that maybe if you follow this kind of things in future, the endometrial scratching can be significantly make the difference. Based on this, we can personalize the immune modulations. So typically for a overimmune activation, luteal support with a high dose of progesterone and the estradiol, use of prednisolone and intralipid, and no exposure to seminal plasma. So we need to bring down the overstimulated immune response. So these are all the modalities recommended. In case of low immune activation, yes, the endometrial injury, mild stimulation and replacement of the frozen embryo in a natural cycle, luteal support with the HCG and exposure to seminal plasma. This kind of specified, we can plan for a subclass of RIF or an RPL, and we need to assess those kind of modalities in those subclass of RIF and RPL. In case of overactivation, the first line of treatment, this particular study is recommending is corticosteroids and a low molecular weight heparin. Second line may be slow intravenous diluted intralipid transfusion. Hormonal adaptation of the luteal phase, in case of particularly low, hyperactivation immune profile, high doses of progesterones are indicated, like up to the dose of 1200 mg vaginal plus intramuscular progesterones. Even the luteal phase has to be substituted by estrogen if there is interleukin 8 levels raised. Supplementation with the HCG again for a low immune profile. This particular study, which the Rosalind Franklin University study, which clearly stated that in case of overactivated, if you use steroid and intralipid, there is a significant improvement in the live birth compared to the control. Again, in low activated, if you do a scratching, there is a significant improvement. Again, the GCSF has a significant improvement compared to control group. So not only in RIF, even in RPL, we can immune profile the endometrium, and they can achieve a good live birth rate. One word about HCQ, we have started using this HCQ tablet. It's a simple drug. Only thing is you need to be careful when you are starting the HCQ. Maybe its ECG is very mandatory. Don't put on the patient who has a prolonged QT interval. Otherwise, it's safe drug. 200 mg OD, 1 or 2 months prior to the conception. Many studies are showing there is some kind of improvement. Again, there are big RCTs are awaited. Paternal leukocyte immunization, that is taking the white blood cell from the male partner and injecting into the female partner, especially for the RPL. Again, there are new studies which is coming. Again, we need to identify a subclass of population by doing something called as MLR-BF, means the mixed lymphocyte reaction blocking factor. Only if after giving a small dose, if there is a rise of this particular factor, they will have a positive response for the LIT, otherwise it's not useful. Again, many studies, a big number of they have done using this particular factor and shown that there is a significant improvement in the live birth rate. One thing again which is catching is a stem cell therapy which can modulate the endometrium immune profile, which we started almost 1.5 years back. We can extract stem cells from various sources. The easiest one is the bone marrow aspiration. Clinical studies, this is a meta-analysis which clearly showing there is significant improvement in the endometrial thickness, endometrial blood flow, and the live birth rate. This is how orthopedician will come and aspirate the bone marrow aspiration in our center using in the iliac crest. So after the suppression, we can use those stem cells for thin endometrium and or in case of RIF, and using the hysteroscope, inject those stem cells into the subendometrial part, not just leaving in the cavity, using the hysteroscope, inject into the subendometrial part at multiple sites. So this is our ongoing study. Maybe I just wanted to present an interim study where we could able to achieve at least 7.2 median thickness of the endometrium. Surprisingly, there is good right now, still the study is not completed, the good implantation rate, good clinical pregnancy rate, and good ongoing pregnancy rate. One word about the microbiome. We know that microbiome plays a very huge role in not only in reproductive medicines, in various diseases, especially the obesity and the diabetes, hypertension diseases. In reproductive, one thing which is fascinating, imagine a 70 kg human being will have roughly 1.5 kg to 2 kg of microbiomes in their body. That's a standard. So it's really playing a significant role in various factors. So one such factor which is they are being evaluating is in reproductive medicines. But right now, as of now, there is no clear-cut guidelines or recommendation by giving the prebiotics, the probiotics, whether we can improve the implantation rate or not. So few things about the evidence-based medicines. Again, the yesterday recommendation, the intervention for RIF, the clearly saying the recommended is review the endometrial estradiol treatment and endometrial thickness, improve those things. Genetic counseling if you are suspecting any genetic abnormality, and optimizing the lifestyle factors. Can be considered is vitamin D treatment, antibiotic if you are suspecting the chronic endometritis is diagnosed, intrauterine HCG administration, PGTA, and blastocyst stage transfer. All other things, GCSF, endometrial scratch, the NK cells, all the IV immunoglobulins, intralipid, all those are not recommended. This particular study, which was published recently in 22, meta-analysis, is clearly showing a good live birth rate and pregnancy rate in case of the peripheral blood monoclonal nuclear cell, PRP, and subcutaneous GCSF. So when there is no clear-cut evidences, or practically we don't know how to do as of now the immune profiling the endometrium, what can be done is better understanding of the immunology, better diagnostic workup will definitely help us. Maybe the immune profiling endometrium is a big hope that it will change our practice. But as of now, can we consider blanket therapy? We can consider, provided it is safe and it's not so expensive. In that, maybe 11 things I would comment. HCQ, safe and cheap. Only thing is, as I told, be careful with the QT prolongation. The intralipid, again, less cost, lesser incidence of reactions compared to IV immunoglobulin. IV immunoglobulin expensive and more incidence of reactions. Low molecular weight heparin, again expensive, but otherwise is quite safe. Only thing is patient has to take a lot of injections. Corticosteroids, less expensive. If you use it for a short duration, maybe less side effects. PBMC seems to be effective, but expensive. Bone marrow stem cells, again, initial studies are showing promising results. Endometrial injury may not be for all RIF. Maybe we need to identify a subclass of RIF and use. Probiotics, expensive, needs more understanding. Paternal leukocyte transfusion, less expensive, need more data in the subgroup. GCSF, again, subcutaneous is better than, few of the studies have shown that subcutaneous is better than intrauterine. Not so expensive, again, need more data. Need not stress upon the adequate progesterone support. Thank you so much. Maybe the questions we can take later.